Hi, good evening, good afternoon. This is Kathleen. I'm going to talk about musculoskeletal assessment, inspect, palpate, range of motion, strength, and sensation. The types of problems that you have with the musculoskeletal system are acute problems, which is trauma and infection, and chronic problems that have to do with overuse, underuse, and systemic problems. Types of problems would include the neck, which is a sprain or fracture, the back, lumbosacral sprain, herniated disc, the shoulder, which is a cuff repair, elbow, which is epicondylitis, gout, bursitis, the hand, which is carpal tunnel, arthritis of the joints, hip, fracture replacement, knee, sprain, dislocation, infection, fracture replacement, ankle, fracture replacement, foot has 26 bones, toe has gout, bunions, hammer toe, fractures, heel pain, plantar fasciitis. The rules for treating musculoskeletal disorders is maintain strength and mobility of the joint, prevent further problems, and treat the pain and avoid infection. Pain is usually treated with Tylenol first, then NSAIDs. Ultram, it comes in 50, 100, 2 to 4 times a day. It comes in long acting. Be careful with people who have benzodiazepine or any kind of addiction. And then your Norco, which comes in 5, 500, 7.5, and 10, 100. Depending on your state, you may be able to prescribe it. And sometimes you use steroid pulse packs for the pain. And then infection, you can have infection of the muscle, the joint, with gouty arthritis, septic joint, the bone, osteo. You can have a sprain, strain, or a spasm. The goal is to know when to image, whether it's the back, the knee, or the ankle, and referral, when to referral. With rheumatoid arthritis, you refer to a rheumatologist almost initially so they can start disease-modifying drugs. With a fracture, you want to put in a splint in the air cast and then send them to ortho. Important for you to know anytime you use a referral, that's important for you to know the bedside manner of the referral physician, what their level of expertise is, what type of insurance they take, and what do they require for a copay. So when you have the musculoskeletal exam, remember that it's focused. You ask them to describe the chief complaint, the trauma, and the history of the present illness. You want to know the onset, duration, and pattern, quality, severity, associated symptoms, alleviating and aggravating factors for you to what is the change of motor function acutely, chronically? What is the alteration in sensation? Be as specific as possible. What is the pain with or without inflammation? And how does that pain affect their activities of daily living, their emotional stability, and their interactions with others, and their sleep and or rest? And then for ligaments, bones, and tendons, it's important for you to know the anatomy, where that started, where it ends, what it feels like, what does that ligament attach to, and what is the expectation of that joint. So when you inspect, it's important for you to know whether they're clothed or not clothed. They have to sit and stand for their spine, especially teenagers for scoliosis. And you want to look at markings. Is that an acute marking? Is it a chronic marking? When you look at ecchymosis, there's no research to say, looking at that, whether it's red or yellow, purple or green, the age of the bruise. You want to go palpate from the outside of the ecchymotic area to the inside. You want to determine if there's a hematoma under that. You want to look at if there's redness and or color changes on the outside of the area of trauma to the inside. You want to know what the integrity of the skin is intact, not intact, how long has it been like that, and discoloration, especially in the elderly or anybody with systemic diseases. You want to know if they have stasis dermatitis, which can be a result of decreased blood flow and or chronic inflammation. For the joints, you want to know the anterior and posterior aspects of the joints, comparing the right versus the left. What is the contour? Is there redness? Is there swelling? Where does the swelling start? Where does it end? Is it painful? Is there atrophy? Is there hypertrophy? I have hypertrophy of the third digit of my right hand due to practicing the Palmer method of writing as a child. Is there guarding with the use of that, or when you touch it, is there an obvious deformity? And then you have to know the vascular status. Even though I'm not big on capillary refill, in terms of your fingernails, you do have to know about capillary refill in terms to that area. So you put your finger down on an area that's supposedly not painful and see if it blanches, and then see how quickly it comes back, and you check the area that is injured versus non-injured. And you want to know the temperature. If both feet are cool, that's not as important if one foot is cool and the other isn't. You want to know the pulse, and the normal pulse is 2 out of 4, and you want to know, is that pulse diminished routinely or chronic, or is it acute? And then when you palpate, you want to palpate along the bone sides. The goal in palpating is no pain, tenderness, or irregularities or crepitus in the feeling of the bones. You want to go from the proximal to the distal part of the bones. You want to feel the joints of the hands. You can either go from the wrist to the ends of the hands, or from the tips of the hands to the end. You should ask about the pip joints, the dip joints, and you should know that the pip and the dip joints are Haberden. The pip and the dip joints are distal, and that's Heberdine, which has to do with arthritis. D for distal, and this is arthritis, Heberdine joints. And the Buchar has to do with rheumatoid arthritis as well as osteo. Your goal is to palpate in a systemic fashion. You may need them to move the joint and to appreciate the head of the joint space and tenderness. When you palpate, your goal is to feel for bogginess, fluctuating swelling, point, tenderness. You want to rule out fractures, bursitis, which is an inflammation, not an infection. You want to palpate the muscle, the tendons, the ligaments. Range of motion is specific to the joints. You want to do passive with the patient, relaxed on their own, position of comfort. Active, you move the joint, and when you move the joint of any joint, whether it's the neck or the arm, you always support the body when you move the joint. You also always go from a non-painful joint to a painful joint. So if they're complaining of pain in their right arm, you're going to palpate and do range of motion in the left arm so that the patient is aware of what it feels like. So when you get to the right arm, you can do it in a systemic fashion, and the patient's aware of that. And you can always talk them through that. The other thing is, it's nice to have some kind of association with the patient, so if it becomes very painful, you have a signal for when to stop. Strength and sensation. The muscle strength is 1 to trace, 5 is to normal. When I do that in a focused exam, especially when people come in with back pain, I have them lay on a table. I put the palmar surface of my hands next to their ankles, and I ask them to lift both of their legs up, and then I put my hands on the side, go out to the side, put them on the bottom, lift to the bottom, and then I put my hands on the toes, and I ask them to pull up their toes, and then on the base of their foot, I put my hands in, act like they're driving, and press down on their toes. And then I compare the right versus the left. And you want to know what is chronic and what is acute. If you do go to assess sensation, please ask them to have their eyes closed. You can do pinprick, light and deep touch, and 2-point discrimination. But this is usually people who have had a huge change in the sensation, and you might see this in a stroke patient or somebody who has a herniated disc and they lose bowel and bladder and they're a surgery candidate. When we talk about imaging, if somebody has any kind of trauma, you always do the joint up and a joint down. In order to do imaging on the knees and the ankles, be aware that there are rules on when to image, so you don't image too much because you are exposing them to some kind of rays. Is that gamma or I don't know, some kind of rays? You need to know what are the red flags for imaging the back, whether they're below 5, above 50, if they're have acute onset or change in sensation, or a history, and some people say history of smoking. In fractures, you may need to repeat in 7 to 10 days. Not always can you determine that there's a hairline fracture, but if people don't improve, decrease the pain and increase mobility, you can have them come back, and when you repeat the x-ray, you may be able to see some formation of osteophytes, which would mean that there's a break and a closure of the break, and so that change in the density on the x-ray is going to tell you that there was actually a hairline fracture. Hopefully in 680 you can allow yourself to be with a radiologist for a day or two so you can get some review of techniques for x-ray reading down. So we have osteo and rheumatoid arthritis. It's important to know the difference, and yes, people can have both. But the definition of osteoarthritis is narrowing of the joint space, and the articular cartilage becomes rough and wears away, and you end up with bone spurs. The risk factors for osteo is positive family history, contact sports, and then obesity. Osteo is a degenerative process without inflammation. The symptoms are hip and knee pain, increasing with activity, increasing at the end of the day. They have minimal morning stiffness. When you do the physical exam, they have a smooth joint with or without crepitus, and sometimes a fusion of that area, as in ballottement. Your goals in treating that patient is to prevent further articular cartilage destruction, minimize pain, increase mobility. Your treatment approach is Tylenol, weight loss, muscle strengthening, assistive devices, glucosamine, chondrite, if that works for you, and steroid injections. And then potentially hip knee replacements. It used to be you had to be over 65 because hip replacements and knee replacements only lasted 10 to 15 years. I think that's somewhat changing. Also for osteo and rheumatoid arthritis. For rheumatoid arthritis, please note that that is an autoimmune disease. It's a chronic systemic inflammation, including the synovial membranes of multiple joints. The peak is age 20 to 40, positive family history. Symptoms are malaise, weight loss, stiffness, symmetrical stiffness. Symmetrical stiffness. Osteo is roving stiffness. Today my shoulder, tomorrow my knee, next my neck. Rheumatoid arthritis is symmetrical stiffness, lasts 1 hour, involves usually 3 joint groups: hands, wrist, ankles, and toes. You have periods of exacerbation and remission. There's a whole series of tests that you can do: a ANA, a ESR, a rheumatoid factor, an X-ray for joint effusion. You can either do those before or after you send them to the rheumatologist who starts the disease-modifying drugs. Methotrexate it seems to be the best drug in small doses on a weekly with pulsing of steroids. NSAIDs is used for pain since it's a systemic inflammation. You have to discuss the ADEs of ulcer and kidney problems. It's important for you to know the dose of your NSAIDs as well as the half-lives to explain those to the patient. Your goal in treating rheumatoid arthritis is the same as for osteo. Decrease the pain, preserve function, prevent the deformity. The only difference in rheumatoid arthritis is you want to decrease inflammation. Remember, osteo is not inflammation. Now we're going to talk about sprains before we talk about knees and ankles. 3 different types of sprain. Grade 1 is no increased instability, and it's a positive provocative test, and we'll go over those 6 tests in 12 to 24 hours in palpable tenderness, but pain with the test. Grade 2 is increased instability, and the provocative test is throughout the ligament. Grade 3 is complete ligament tear, takes a long time to heal, gross laxity with or without pain, and a positive provocative test for instability. And your goal is to know the difference between those 3 types of sprain. So your goal is to know, is it a complete or a partial sprain? And grade 2 and 3 is persistent joint laxity, and that increases the risk for a future sprain. Anytime you've sprained a ligament, what you've actually done is stretch that rubber band. It will never go back to normal. So the goal in any type of working with somebody with a sprain is to get them to use the appropriate wear, whether it's knee wear or footwear, to warm up, to warm down, and you may even tell them what activities will increase their muscle strength or decrease their muscle strength. Now we're going to talk about backflow, because you're going to have so many people that come into your office. About 60 to 80% of all adults have back pain for about 1 month of a time. Back pain is usually the culmination of many events, and the main event is poor conditioning. When somebody comes in with back pain, your goal is to determine, do they have radiculopathy and or sciatica. Radiculopathy is pain, numbness, tingling, weakness along the course of the nerve, whereas sciatica is shooting pain over hip and radiates the foot with numbness and weakness of the leg, okay? You can have it at the cervical area, the neck, or the lumbar area, the back. The risk factors for back pain are inactivity, poor conditioning, spinal stenosis, scoliosis, and my 2 favorite risk factors, smoking and obesity. Usually the person comes into you and they complain of stiffness, spasm, reduced range of motion, and some relief when lying flat. Your physical exam is you want to find out what area of tenderness do they have, paraspinal area of tenderness, do they have a spasm, and does that increase or decrease with raising their leg. Your treatment plan is bed rest for the shortest period of time. Use of cold packs, alternate with heat. The best cold pack there is if you have frozen blueberries or peas, because they're small and round without sharp edges. You can put them on your back. Make sure that when you talk about heat and cold, that you tell them to put a spacer between their skin and that article so that they don't have freezer burn of their back and or heat. Use of NSAIDs. Remember, you want to know their half-life. You want to know their comorbidities. Do they have chronic kidney disease and or peptic ulcer disease that would increase the chance of a GI bleed? Always use Tylenol. It's a great drug. And then a muscle relaxant or sedation. And this is Soma and Flexeril. Be sure to know when you use those drugs, many people cannot drive on those drugs, care for small children, operate heavy machinery. I don't know what that means. For some people, it's operating a sewing machine. Other people, it might be a vacuum cleaner. Some people, it may be loading the dishwasher. Back pain imaging rules. It's important for you to know that treatment plan for the back pain depends on several factors. 1, workers' comp. Was this Has this person had this injury to do workers? They gave some statistics like 85% of your back pains were done in the first day on the job. What is the age of the patient, young or old? What are the comorbidities? And what are the two comorbidities I consistently address with back? Obesity and smoking. What is the level of discomfort that they have in explaining this type of back pain? And the reason you want to do back pain imaging is you want to know when to refer them. Now, if they have limb pain, limb dysfunction, bowel dysfunction, bladder dysfunction, they need to be referred to either an orthopedist or neurosurgeon. You want to know what type of imaging to do. The MRI gives you the soft tissue. The CT gives you the bony structures. Now we have the knee test, and I want you to know these. Knee tests are to determine the sprain, laxity, and tear you're checking for stability. So here's a few hints. The ACL is tested by the anterior drawer test and the Lockmans. A for anterior, L for Lockmans, the ACL, anterior, and Lockmans. The PCL is the posterior drawer test. The valgus and the varus is a test for laxity. And they have laxity at full extension. The McMurray's is for meniscal and for McMurray and for meniscal, and you hear a popping sound. So your test question is, I will ask you to match a test with what it's testing for. So with knee pain, what you want to know is when they come in with a focus exam, what were they doing prior to the injury? What did it feel like immediately? Was there pain or a sound immediately? What happened 30 minutes later? When were they able to walk? Were they able to not walk later? What was the immediate treatment? Did they wrap it? Did they ice it? Did they use an NSAID? Have they had an injury there before? What were they doing? Did it invert? Did it exvert? Did somebody kick it? What was the injury? Because you want to determine if they have a complete or a partial ligament tear. And you want to know where is the instability. You want to know edema, noises, instability, popping, and clicking. You want to inspect, palpate, and percuss. For the knee imaging, I'm not going to ask you to give me this slide. I just want you to know, why do you image? You want to rule out a fracture versus a strain, because a fracture sends you immobilize the area and you send them to an orthopedist. So that's the main reason you're imaging. Is it a fracture? Is it not a fracture? The same with the ankle and the feet. You want to know the type of trauma, what the patient heard, what the patient felt, how soon the pain came on them. Is there tenderness? Is there edema? Is there ability to stand and walk? Is there prior trauma? What was their shoe? When we talk about ankles and feet, you want to know what's the difference between the inversion and the eversion and what that means in terms of what's torn. As well as the imaging, you want to be able to rule out a fracture. So you have to know, where are the points of tenderness. Summary of musculoskeletal. You want to know, what is the history. And the focused exam, is the problem acute, meaning that there's trauma and infection. It's chronic, meaning there could be overuse, underuse a systemic problem. You want to know the rules. The goal is to preserve the function of the joint and range of motion, prevent deformity, control pain. The goals of pain are Tylenol, NSAIDs, Ultram, Norco, steroid pulse therapy. If you want to determine if there is an infection, whether it's gouty arthritis, a septic joint, and or is it an infection of the muscle or the bone of osteo? You want to find out if they have a sprain, strain, spasm, or fracture. You want to know when to image, and you image when you think there's a fracture. You want to know when to refer rheumatoid arthritis to a rheumatologist, fracture, you splint, air cast, and send them to ortho. You want to inspect the skin, the joints, the vascular status. You want to palpate the bones, the spaces, the muscles, and the joints. You want to look at range of motion specific to the joint, active and passive. You want to check strength and sensation. You want to compare the right and the left, acute and chronic. You want to identify sensation with their eyes closed, pinprick, light and deep, 2-point discrimination. You want to know when to image and why to image and what the difference in imaging will allow for your treatment. What is the difference between osteo, which is non-inflammatory, one joint at a time, due to increasing pain with activity of the hip and the knee, rheumatoid arthritis, which is an autoimmune disorder, chronic systemic inflammation, malaise, weight loss, stiffness, positive family history, hands, wrists, ankles, and toes, inflammatory, send them to a rheumatologist, decrease inflammation, control pain, preserve function, prevent deformities. And for the injuries, you want to know the difference between grade 1, 2, and 3 sprain. You want to determine in back pain when to image, when not to image, what's the difference between radiculopathy and sciatica, and what the treatment plan is. In the knee, you want to determine Apley, Lockman, McMurray, anterior drawer, posterior drawer, valgus, varus. For the knee pain and the ankle pain, you want to determine stability, instability, when to image, and all those things will tell you, is there a fracture, is there a sprain, so that you can give the appropriate treatment plan. Your goal in ankle and knee is to get those joint moving as soon as possible. Thank you so much.